So welcome. This is an COVID topic put on by OHCOW. I'm Krista Thompson, an occupational hygienist. And today our topic is air quality synergies between public health and occupational health. Okay, we used a big buzzword like synergy, so we're going to have to live up to the big buzzword. Let me see if I can advance my slide here. Okay. So first, I want to talk about the hierarchy of controls before we even talk about ventilation. As an occupational hygienist, this is what I live with and work with every day. So starting at the top, we have elimination. Whenever possible, we'd rather physically remove the hazard. It's not very common we can do that, but one example I think of is when you're getting new equipment, for instance. If you can get equipment that is less noisy or uses less chemicals, physically remove the hazard that way. But more often than not, we do have to go down that inverted pyramid a little bit. Substitution is really common where we're replacing the hazard. Now we have to take care here that we are actually using something less hazardous. Common example I like to think of is asbestos. We used to use asbestos in everything, so it is still in some buildings. But with new buildings, we aren't using asbestos insulation anymore. We typically use fiberglass or something else like that. So we've substituted for something less hazardous. Next, we have engineering controls. This is where ventilation falls. Control booth in a factory would be an engineering control. This is where the engineers shine. This is where we're going to be talking most of the day. Going down the inverted pyramid a little bit more, we have administrative controls. So we're going to change the procedure. We're going to change the process so that there's less exposure. And then finally, our last resort, PPE, personal protective equipment. Now, sometimes we have to wear PPE, and I'm thinking of an asbestos remediation project. You could be on a remediation project where there's HEPA vacuums and wet wiping and all the engineering controls and administrative controls that you can possibly have, but you're still going to be wearing that respirator just in case those controls aren't effective enough to make sure that you're not breathing in asbestos. There are times where PPE is not used as a last resort, it's used as a first resort, but ideally we do really want it as our last resort. So let's talk about ventilation. So the two types of ventilation, mechanical ventilation, we've got general dilution ventilation, which is what we're going to be focused on today, and local exhaust ventilation. And of course there's, without the mechanical side, natural ventilation. That's where you're opening a window, setting up a fan, maybe to bring in more fresh air. Local exhaust ventilation, this is something that's at the source. So think of a fume hood or those, I just blank on the name for it, the little movable fume hoods that you can use for welding. Somebody was there, maybe trying to help me, but didn't quite come through. That's okay. I think everyone knows what I mean. General dilution ventilation, there's a few goals to general dilution ventilation. So general ventilation, this is used to heat and cool. So this is for occupant comfort. This is used to provide fresh or filtered air. It's used to reduce or dilute the contaminants, and it's used to reduce fire or explosion hazards. So when we're talking about replacement of contaminated air or filtered air or a combination of both, we want to make sure that that fresh air coming in is clean air. So we don't want the intake near where vehicles idle. A couple of rules of thumb for ventilation. This is excellent for contaminants that are slightly to moderate toxic, ideally with a good warning property, but doesn't have to. And relatively low quantities of contaminants are generated. So you are not having general ventilation where there's high qualities of solid particulates. So it's so dusty you can't see anything. General dilution ventilation is not going to be enough for that. So we're talking offices, we're talking healthcare settings, right? Although there are sometimes local exhaust in healthcare, we're talking factories that don't have lots of chemicals in them. So when ventilation system, just briefly, there's the supply side and the exhaust side. The supply side has the air inlet, air filtering equipment, heating or cooling equipment, a fan, ducts, and then distribution registers. The exhaust side has the intake, so it's basically the reverse, ducts, cleaning air devices, fans, and discharge stacks. There. Here it is in an image. Don't worry, there's no test on this, but basically we have the blue air, the fresh air coming in. I'm using my hands as if you can see me pointing at my screens. We have the blue fresh air coming in, getting distributed to the different work areas, and then the orange air is leaving. And look at that in the middle. I don't know if you can quite tell, depends on how good a screen you have, but sometimes, actually quite often, some of that return air is filtered and recirculated. And so that's really common, but it's got to be filtered. That's really important. Okay, and something else you'll hear us occupational hygienists talk about, we really nerd out when it's ventilation, we really do, is air changes. And air changes, really easy. This is airflow divided by the volume of the area. So how much air is coming in divided by the volume, not the square footage, the cubic footage of the area. This is a really good single number criteria, quick and dirty math, and it's applicable to any size room. There are some disadvantages. This assumes you have complete air mixing, so there's no dead zones. There's no dividers set up. There's no plastic dividers between areas to impede that room mixing. And it does not consider local exhaust ventilation or use of portable air purifying units. So air changes is not a perfect calculation. We do have better calculations when these other things are in place, but it's a nice, quick and dirty way of looking at how much air is coming in. So what are I talked about contaminants. What are the common contaminants being removed by ventilation? Carbon dioxide. We are all making carbon dioxide right now. We are the biggest source of carbon dioxide in the vast majority of settings. Ventilation is also removing the normal smells and body odors coming from people. It's removing low levels of contaminants from work processes, some fumes, particulates, and vapors. As long as those are high levels, the general ventilation can handle that. And it's removing aerosols, and this includes aerosols that contain airborne infectious diseases like COVID-19, measles, chickenpox, tuberculosis. May not be enough in some settings. That's why in healthcare, someone working with a TB patient, for instance, they're not relying on just the air in the room. They're also wearing a respirator, but it can be enough in some situations. So I've been yammering on about ventilation, and if you work in occupational health like me, you might have been geeking out over the ventilation stuff, because like I say, we occupational hygienists, we just love ventilation. But how is ventilation an intersection between occupational and public health? Isn't it an engineering thing? Well, first, let's take a step back and talk about what is public health. So I've got two definitions up. One is promote and protect the health of people and the communities where they live, work, and play. And another definition is organized effort of society to keep people healthy and prevent injury, illness, and premature death. Okay, so what is occupational health? Again, I've picked two definitions. Protect workers against sickness, disease, and injuries arising out of their employment, and promote and maintain the highest degree of physical, mental, and social well-being of workers in all occupations. So when you listen to those definitions, I think you can see how there is nice overlap in what we do. So you're probably wondering, don't engineers deal with ventilation? Well, engineers design the ventilation and they often assess it, but occupational health and public health also have a role in assessing the ventilation and addressing how ventilation impacts everyone. You may have heard carbon dioxide talked about a little bit. Very briefly, carbon dioxide is a measurement of how adequate your ventilation is. General ventilation should be high enough to keep CO2 levels below, and this number that we keep it below varies by the agency you consult. 1,000 parts per million is sometimes used as the criteria. 800 parts per million is sometimes used. Either way, these are comfort levels. These are not toxic levels, because we're using carbon dioxide as a proxy measurement to see if ventilation is high enough to remove the other contaminants that we are actually concerned about, that all humans produce. The CO2 doesn't tell us if other contaminants are present. So a thorough indoor air quality situation is going, or survey is going to look into so much more than just carbon dioxide, but carbon dioxide is a quick and dirty way of actually seeing, okay, is there enough ventilation in there? Should we look into this a little bit more? Okay, so I yammer not enough. That's my background into occupational health and ventilation. I want to talk about why you're here today, or introduce the person why you're here today, Dr. Thomas Piggott. Dr. Thomas Piggott started with Peterborough Public Health in December 2021. So we're in the middle of, I can't say the middle because I don't know when the pandemic's ending, but in the middle of chaos in that point. In his position as Medical Officer of Health and CEO, Dr. Piggott brings experience working at various levels of public health in Canada and internationally. Prior to Peterborough, he worked as the MOH and VP lead for population, rural and remote health in the northern region of Labrador, and as a field doctor with MSF, Doctors Without Borders in the DRC. Dr. Piggott completed his medical training, residency in public health and preventative medicine, and his PhD in health research methods at McMaster. He's involved in research, teaching, clinical work, and is a father of young children. And I can say, as another parent of young children, parenting in a pandemic is its own set of challenges. So let me figure out how to stop sharing my slides. I think I clicked this, so it should be, there we go. Good, I didn't leave when I did that. So Dr. Piggott, thank you so much for being here today. We can't thank you enough.
Oh, it's a pleasure. No, I'm really glad to be here. I don't know if you can hear me okay and see the slides.
Yes.
Well, the piece in my bio you didn't capture is I had about a month, some rotations at one of the OHCOW clinics as part of residency training. So know about the great work that OHCOW is engaged in and the importance of occupational health, workers' health and safety, sort of firsthand from when I was in training. And it's a real pleasure to be here with the group and with all of you today. So thanks for the invite. I'll go through a slide deck that I have here. Happy to have conversation here, questions and thoughts as we go. I always start with a declarations of interest slide, and this is mine. In particular, I want to acknowledge the land that I'm personally calling in from today, which is Treaty 20 Mississauga and Anishinaabeg territory, the region referred to as Nogojiwinong. And so Peterborough Public Health also, I want to note, is one of only a couple health units that has a governance agreement with First Nations in our region. So Curve Lake First Nation and Hiawatha First Nation are also governors in our health unit. I'm employed by Peterborough Public Health, a little bit on my education, certainly a personal background of significant privilege, which I think I bring to the work that I do in public health work and advocacy, which I think is important to acknowledge and be mindful of. From a interest standpoint, intellectual interests, I am involved in the grade working group and guidelines as my area of research in particular. We'll talk a little bit about one of our upcoming guidelines on post-COVID condition, long COVID as part of this, and co-editor of a book called Underserved. And from a financial conflict of interest standpoint, I want to be very clear that I've never received any kind of pharmaceutical company money or dollars, and some of the past research work that I've done has received some funding or travel contributions. So that is my declarations of interest. Perhaps not on this slide, but most important to this topic is I am not an occupational health expert. I'm a public health and preventative medicine specialist. I also am not an engineer. And when we're talking about indoor air quality, engineering skills and knowledge is quite critical. Come from a family of engineers. I broke a bit of a line of grandfather, father, and brother. I have tremendous respect for the expertise engineers bring to this conversation, which we'll talk a little bit about as well. I will not talk a lot today about the technical aspects of ventilation and indoor air quality, certainly not from an engineering standpoint. And so I thank you, Krista, for the introduction with some of the slides around that and some of the information shared. But I'm going to talk a bit more about kind of the COVID journey, COVID context and importance, and why our Board of Health has been doing more advocacy on indoor air quality. So obviously we know we're in a very different place in the COVID-19 pandemic. People often ask me, is the pandemic over? I still say certainly not, but we're in a better place. And that is largely thanks to the advent of vaccinations in particular, but also everything else that we've done through this period. But the pandemic is still here, and I think it will continue to perhaps wane in the burden. I hope anyway. We have to maintain humility that we don't know exactly where it's going, but I hope it will continue to wane in its burden. And the kind of when the pandemic's over will be a question that we can only answer from the rearview mirror looking back. And so at the stage we're at now, we're obviously not in the same stage of significant public health measures, and we've moved to a stage of more importance of individual level decision making and health measures, which is challenging from a public health standpoint to manage a continued pandemic. So why do we want to improve indoor air quality? I think many people listening will know, but in particular, it's around reducing the transmission of COVID and other airborne diseases, but it's for other reasons as well. There's benefits, co-benefits to reducing other airborne contaminants, improving health outcomes because there's decreased airborne contaminants and airborne related illnesses, communicable and non-communicable. We also want to do it because we know better quality air leads to better academic achievement and better performance in the workplace and less workplace absenteeism. So this is a dollar for dollar good investment and a logical thing to be doing for many more reasons than just COVID, which is predominantly what I'll focus on talking about today. From a workplace and workers' health standpoint, COVID's been significant, perhaps the biggest workplace health threat that OHCOW folks would have seen in the life of OHCOW. During the pandemic, there were a significant number of WSIB reports around COVID-19 claims, and they've been increasing. 2020, just under 5,000, just under 8,000 in 2021, and well over 10,000 in 2022. And in part, some of this is related, obviously, to long COVID implications too, not just acute illness and disease. There's been a significant transmission in workplace settings, right? Workplace education, indoor settings is where outbreaks happened. And so from a workplace health standpoint, trying to stop and prevent these transmissions and these outbreaks is really quite critical. Again, I mentioned the pandemic's not over. There's been nearly 800 deaths in Ontario in 2023 so far. In my region, in Peterborough Public Health region, a small region, there's been 3 deaths in April due to COVID-19 so far. And it's significant. Obviously, the highs and lows are not what they once were, but the baseline level of transmission continues. And many people are still getting infected, getting sick. Many of those infections may come with longer-term health consequences, may come with hospitalizations and deaths, but fortunately, because of vaccine and how effective vaccination uptake we've had, relatively speaking, what we've seen is a decrease, a bit of a decoupling between hospitalization and severe disease and death with waves of COVID transmission. It certainly hasn't demonstrated that it is a seasonal infection yet at this stage. We kept wondering when would COVID kind of go the way of other respiratory infections for a variety of reasons. We have respiratory outbreak seasons in Canada, mainly because it's cold and we're spending more time inside and we're congregating and closer to others, and we have more indoor air, poor air quality gatherings, and we see transmission. But COVID's not particularly taken a seasonal pattern yet, though certainly we have seen waves corresponding with highest risk transmission periods. I want to talk briefly about long COVID, post-COVID condition. It's also critically important as we talk about COVID. It's not just about hospitalization, severe disease, and death. It's also the broader disability from long COVID, and it is thought to affect some 1.4 million Canadians or more, according to the chief scientist's report. Comes at significant financial cost. The definition of long COVID: symptoms and medical complications that persist, return, or emerge 12 weeks after the initial acute infection phase, at least 12 weeks after. And this is persisting for some people who had infections at the very, very beginning in the first wave of COVID. Many of you may know people affected, but I know, for instance, a healthcare provider that I know really well was bedbound for nearly a year from impacts of long COVID, and still continues to have significant impacts. So it is disabling, and has been this significant mass disabling event for Canadians. And so it's critical in continuing to prevent for COVID, but also for other respiratory infections into the future. The measures that we can take to prevent are critical. I want to put a brief plug in for the newly launched Canadian guidelines, CAN-PCC guidelines. Those are underway, and the recruitment to get input and support. If you Google, you can see the sign-up sheet. I can also paste it into the chat here after I'm done sharing my slides. But there is a call for members, both expert, professional members, bringing those perspectives, which we're trying to get diverse perspectives, and also people from the public as well, in particular people affected by PCC. I mean, I think the fundamental reason why we're talking about why indoor air quality is important for COVID is because we've learned through the pandemic that COVID is airborne. Here's just some of those quotes, sort of clearly communicating, but the Ontario Science Table noting aerosols play a role, Health Canada noting that aerosols play a role. So given that the problem of COVID transmission is airborne, the solution becomes clear. We need cleaner air and less virus hanging in the air and transmitting. The pandemic has been a big melting pot of measures to try to control the infection, from lockdown and complete travel restriction and quarantine in some provinces. I spent a good first half of the pandemic in Newfoundland and Labrador, where there was a mandatory 2-week quarantine period if you were a resident returning, and that you wouldn't have been approved for visiting without special circumstances. And so, the context of COVID response in Labrador, for instance, in the first half of the pandemic was very different because there was virtually no transmission of COVID because importation was eliminated. There were a handful of cases, and little to no onwards transmission from those cases as a result of those measures. And I think Krista did a great job talking about hierarchy of controls when we were talking about this, but certainly where we're at now, which is down on the bottom with most of the top of the pyramid gone, PPE is good, but is a last resort. And certainly masking is important. I continue to mask in indoor locations, and we continue to require masking in our building as a health facility. But going about, you see many people are no longer masking, and to some degree I can understand. We did not have a culture of masking before, unlike some other countries and parts of the world, so it's probably difficult to have the behavioral change last in a long way, and may take many years to really normalize masking as part of the response to respiratory viruses. For those that aren't familiar with the public health story of seatbelts, it's an interesting and telling one, because the seatbelt, as we know, the retractable seatbelt as we know now, was invented in the 50s in California, and was first put into vehicles in the late 50s as an optional add-on to those who were interested in purchasing a seatbelt in their vehicle. From there, Ontario was the first province to require seatbelts into the late 60s, I believe it was. And the time period from the first province to require seatbelts till the last territory was over 30 years. As that continued to evolve. You can't see it, but on my wall over here, I've got this nice license plate from Prince Edward Island in 1980 that says seatbelt saves lives, and that was the year before they required seatbelts. And unfortunately, requiring things tends to, as we've seen through the pandemic, lead to better uptake and often not much concern. I mean, personally, I wouldn't ever think about getting in the car and not putting on my seatbelt anymore, just like I wouldn't think about getting on my bicycle and not putting on my helmet. And that normalization will likely take some period of time. And the fact that it took 40 years for seatbelts gives me some solace that it's probably a long journey ahead of us. But I think the other thing about PPE and masking is it needs to be proportionate to the hazard, and that needs to be contextualized. And the hazard changes when we see waves of COVID, and if it does start to follow more of a seasonal respiratory pattern. I've used the metaphor of snow tires, and there may be the need to restart some of these lower order hierarchy of controls, like masking and other strategies more frequently and more vigorously, and perhaps even requiring them across certain settings when the risk is higher. And having that proportionate response to risk, I think, is quite important, because we know something that modulates risk, like a mask, that may have a 50 to 80%, depending on the kind, effectiveness, reducing risk, depends on baseline risk. So if there is no baseline risk, if there's no COVID going around, then the relative risk is not as effective at decreasing. If there's a very high baseline risk, that becomes much, much more effective and important. And so I think it's important to contextualize as we're talking about these things in the broad hierarchy of controls. But moving up the pyramid, the engineering controls is one that is not sort of the public health measures that people are ready to have moved on from in the pandemic, but one that with some investments can be really critically effective in the background, working there. As we're talking here, I know our HVAC system in this private room I'm in has been tested and is working vigorously. I also have an in-room air cleaner that is working away, and I'm in here with nobody else, and so I'm not wearing my mask, right? I think if things can happen in the background, they will be more effective, and we'll have better compliance. And obviously we know transmission of COVID, little to none outside, very infrequently, most of it in indoor settings. So how can we make the indoor air more like the outdoor air? And I'm going to talk a bit more about that as we go along. But before I get to kind of indoor air quality and why it's so important, I want to talk a bit about my coming to realization on COVID and airborne transmission. I am also a researcher at McMaster University involved in systematic reviews and guidelines. And in early 2020, in February, March 2020, we started into a massive systematic review effort to look at not only SARS-CoV-2, but SARS-CoV-1 and MERS, the other coronaviruses that have caused pandemics, and the evidence of physical distancing, face masks, and eye protection. And in this review, there was a signal, an important signal, that N95 masks provided greater protection. And that signal to me was quite critical to questioning my traditional teaching and thinking on COVID and on respiratory diseases more broadly. My first pandemic that I was involved in my career in public health was H1N1, and through H1N1 there was a lot of debate around appropriateness of PPE and whether N95s would provide an added benefit, and there wasn't a lot of clarity that emerged from that influenza pandemic on that question, but it was in the back of my mind. And certainly when you think about the cost, which was largely fairly minimal compared to a potentially deadly or disabling virus, it made sense to me that higher quality masks would make sense. And it made sense to me as well that thinking about this virus using a bit more of a precautionary principle lens, that there could be components of airborne transmission was really important. So this was April 2020 that we did this work. It was published in the Lancet in June 2020. Fast forwarding, I think now there's been a lot of arguments. There continues to be a debate, but there's been a lot of arguments, and now provincial and federal health bodies really endorsing the fact that COVID has an important airborne transmission route. So when I was working in Labrador, this was just my approach and thinking and communication on it. I started December 1st, 2021 in Peterborough, and a few days into my job, I was grappling with Omicron, which really changed the game. We saw far more transmission than before, and I really felt it was really critical to up the messaging on airborne transmission and the need to upgrade masks. But now, you know, I think the evidence is more clear. We've seen significant super spreader events. I saw one early in my pandemic response journey in Newfoundland and Labrador that, to me, said clearly there is not just droplet contact near person-to-person transmission. There's something more going on with these super spreader events. It doesn't make sense that somebody truly coughed in everyone's face in a group of 200 in a small, poorly ventilated room. It also became clear through long-term care home studies, and I had a case where there was clearly transmission that wasn't facilitated by staff, but went from one resident to another resident, and they had a shared bathroom that was never used at the same time. There's about 30 feet between them, and there was clarity to me that there was long-range transmission happening. Heard cases of outbreaks where there was perhaps lingering aerosols in an elevator and no direct contact between people. So, you know, we end up where we are now, where there's certainly much more clarity. When we assess the certainty of the evidence because of the types of evidence in the studies, often we would classify this evidence as indirect and lower certainty, but that doesn't mean it isn't the you know, truth that we should be practicing with and advising the public on at this stage. Certainly, evidence can change over time, and maybe on this one, the evidence will change over time. And I remain open-minded to be convinced otherwise, but for now, there's clarity to me. We need to be treating COVID and potentially similar diseases as a airborne transmission event, and we need to be responding accordingly from a public health standpoint. So ventilation is critical. The evidence on ventilation is that, you know, buildup of viral aerosol particles is dependent on how infectious somebody is, the kind of activities. We know, you know, singing and different things like that can produce more aerosols. The size and space of the ventilation is quite important, but certainly the buildup of particles is higher in a smaller, poorly ventilated area. And there's things we can do as a result. We can try to spend more time outdoors, right? I do more walking meetings than I used to, and that can be lovely. We do lots of outdoor activities and things like that. It can be tough in Canada, but still no excuse, you know, get warm, snowsuit up, and it's important to get outdoors. We can potentially dilute contaminated air and or remove contaminated air through ventilation, windows, doors. You know, sometimes I hear from folks that we can't do more about ventilation because of the cost. And to me, cost is no excuse for two reasons. One is we have to look at the consequences of not acting and the cost of illness and infection. It definitely is worth the investments, but also there are some low to no cost strategies, and in certain settings, ventilation, opening windows, doors can be quite effective. You know, there's parts of my personal home that really aren't well serviced by our HVAC system. And I am able to, if I have guests or people over, open windows and doors and really get air flowing so that I know and can be assured, and I've done some measurement with CO2 monitor and kind of have assessed before people have come over, but I can know that there is better quality air that folks are breathing. And distance is still helpful. I mean, certainly the metaphor that I sometimes use is a silly one, but passing gas, right? If you pass gas, you're creating a gaseous substance that is often smelt more when you're closer than at a distance. So, you know, with the concept of airborne transmission, we know that distance is sometimes not enough, but it does modulate risk, it does decrease risk. And so regardless of ventilation status, these strategies and then the other lower tier strategies such as PPE on the pyramid can be helpful and important. One thing I don't have here, but is clear, On the hierarchy of controls, the highest one, elimination, something that's clear is that we need people to stay home when sick. And it's really unfortunate we've lost a provincially mandated paid sick leave, but I think that continuing to advocate for strategies around paid sick leave is important for this and future pandemics, because we don't want people who are infectious being able to spread infection while they're the most infectious to others around them. And so the elimination part of that pyramid is important there too. I'm going to talk briefly about, and I don't know how we're doing, I think we're still good for time, but I'm going to talk briefly about another airborne disease that I did some work on prior to the pandemic, and I was one of the methodologists helping with this guideline, WHO's TB Infection Prevention Control Guideline. TB is something that there hasn't been debate about being airborne. It's something we all know and have known for a long time is airborne, and we assessed the evidence on prevention of TB transmission, and we looked at various forms of ventilation systems. Again, this is a global guideline and audience, and one of the significant challenges that WHO has to grapple with is cost of certain interventions, especially for lower income countries and settings. And we looked across at the evidence, and the evidence was clear. I'm going to just fast forward, quickly through, but the evidence was clear that these are all important and effective strategies, and you need experts, which, like we talked about, can be engineering, can be infection prevention control, can be occupational health, but you need experts that can assess a space and recommend appropriate interventions to reduce transmission. I'll just put a little plug for this recommendation map, a rec map. You can see at who.tuberculosis.recmap.org. And you can actually check out, if you hover then over prevention and look, you can see environmental controls, some of the ventilation and upper room germicidal UV recommendations that there have been over the past little while from this guideline and other WHO guidelines on TB. I'll also put a plug in now about the eCOVID rec map, which you can get by going to I think it's recmap. I should put the link on. I'm sorry. It is covid19.recmap.org, covid19.recmap.org, and you can see a massive number of guidelines that have been extracted and critically appraised, and recommendations put up on infection control, on prevention of COVID-19. You can see a number of interesting recommendations. So there certainly is not nearly as much evidence that's been incorporated on ventilation as I'd like to see yet, and that's one of the gaps that we're hopefully going to be filling as we set out to answer questions around post-COVID condition, because again, the most important part of preventing long COVID is preventing transmission of COVID. So I think that one of the challenges with COVID-19 is we've often relied on a patchwork of solutions, and we haven't taken a big picture comprehensive strategy. This patchwork often relies on individual behavior, and unfortunately we know that sometimes people don't always make the quote unquote best personal health choices. Maybe imperfect information and maybe education will help with that. But it's unfortunately not just about education. Many people have barriers. There could be social factors or stigma, or there could be economic factors, not being able to afford things. There could be decisions that people are trying to make a decision between one thing or another, and they have to make a hard decision. So clearly personal choice is not the best approach, and IAQ work is something that I think we could have a multi-sector, multi-level approach to really ensure that the places that we live, we learn, we work, and we play do more to address the prevention of COVID-19. So improving ventilation. Peterborough Public Health's been really interested in this. One of our first initiatives, and a thanks to partners, I don't know if there's anyone on the call that had help, but there's a really great group, mixed group of partners that came together, including companies selling CO2 monitors and advocacy groups around COVID-19 and CO2 monitors. And in a little over a year ago now, we had collaborated with the Peterborough Public Library, and we started a CO2 monitor lending program, which I think is great because these monitors can be a little bit expensive and probably not accessible to everyone. You know, they're actually not too expensive, and some people love the idea of having that information all the time. But for many people, just getting the information themselves and trying to make an assessment and thinking about what they need to do and then putting into practice can be helpful. My wife's a primary care provider and did this at their clinic, and you know, she'd looked at CO2 levels before, and then they put a bunch of different strategies in place around their HVAC system and in-room cleaners, and then they looked at CO2 again after, and they could see some improvement in some areas, and then they could kind of incrementally quality improve the whole process, and it was really interesting and great, and it was with a monitor that, you know, she borrowed from the Peterborough Library. I think doing this in a variety of settings and just increasing knowledge and awareness so people can make good decisions is really critical. So that's been great. And then more recently, with significant, you know, staff support and collaborators, I'll thank some folks, you know, such as Joey Fox, who have been really critical providing input, Niagara Public Health and Dr. Hirji as well. Others have certainly done a lot of work in this space that we built from, but we in January brought a report to our Board of Health so that the board could advocate on a broad variety of issues on improving indoor air quality, on looking at policy levers locally in their own facilities for First Nations, for municipalities, on interventions that the provincial government, both from a Ministry of Health and Ministry of Municipal Affairs and Housing standpoint, could do around the building code and around the importance of IAQ and heightened standards, and around funding opportunities for technological advancements, especially for, you know, small businesses and others who you know, may not have the means to really assess and improve this. I was really pleased when I did my tax return this year to see the federal grant, the tax reimbursement for dollars spent on indoor air quality improvements are tax deductible, and I think that will hopefully get people thinking and perhaps trying to do more about their indoor air quality, knowing that it could be a tax deductible business expense. So I think it's great, but I think we do need to do more to equitably ensure that there's access to funds to make these improvements. And the last piece was certainly to liaise with other sectors, recognizing public health as a lens here, but environmental engineers, municipal building departments, businesses, and occupational health folks, obviously, and infection prevention and control across health facilities. These stakeholders all have a role to play, and we need to get people rallying together behind indoor air quality improvements. So you can see we did a number of advocacy letters and did get a fair bit of both media and social media attention to this to really drum this up. I think it's important to continue to do this and to do more. It was great to see it across a range of settings, and I think it's because people think that it is pretty clear. You know, what we've learned through COVID can't be forgotten, and improvements to indoor air quality, such a great opportunity that really is win-win and comes with significant savings and benefits when you look at the health consequences of inaction. Obviously great to see some provincial attention both here in this province and in other provinces around this. In my role, can't really speak to specific, you know, parties and bills and policies, but I think that more attention is definitely needed, and I really hope that government does start to draw more attention to indoor air quality and investments. Certainly here locally, when we've been looking, we've had lots of conversation with schools, and that's been an important collaboration, as well as business operators. We're creating resources for our public health inspectors to use in the field. They're out and about in a lot of settings all the time, examining safety of things like water and food safety, why not add air safety, indoor air quality improvements, and education around that to their list of skills so that they can help to support people that are interested in improving this, because I think it's quite critical. Again, other provinces too, seeing this internationally, I think there's a lot of momentum building and it can't be lost. I'm going to come to a close here saying that, you know, it certainly seems like a lot. It seems like a daunting task to really improve indoor air quality. But we've actually done it before, and it shouldn't be seen as too daunting of a task. Certainly it was a lot of work and took decades, but we've made significant progress on smoking as the leading preventable cause of death. And, you know, many of you probably remember the days when there was a smoking section in the restaurant, because as long as you have people sort of smoking off in a section, you know, not being too close, it's okay, it won't matter. People probably remember smoking on airplanes, but of course, you know, smoking too is something that is an airborne indoor air quality health threat. And we no longer see this. And you know, if any of you have traveled internationally where this progress hasn't been made, it's always very jarring and surprising. And so the progress we've made in smoking, I think, needs to be a bit of a playbook to the progress we need to make in indoor air quality more broadly. You know, this is a poster on bylaws and changes then to Smoke Free Ontario Act around public playgrounds. Not only is it indoor spaces, but even outdoor spaces. And so can you imagine that we've made as much progress as we have? It's pretty incredible. And I think we need to learn from the smoking story because it's saving tons of lives and really critical. You can see just that impact through smoking prevalence, and it continues to be a priority. The work on smoking is not done yet, and we continue to try to push that rate down lower and lower. But look, from an average of nearly 25% of people smoking down to nearly 10%. And this is in a period of a couple decades. I mean, public health and associated stakeholders and fields can make incredible progress if we really put the energy and attention to it. So I hope for IAQ, it can be a next big public health achievement and improvements in IAQ. It's not something public health can go alone on. We certainly have an advocacy role to play. We need that suite of experts. I want to thank some particular folks, especially people on my staff here that have supported this work. I want to thank you know, partners that have been working with us on this, and especially then to OHCOW for the invitation here today, and really grateful for the chance to speak with you all, and hope that you'll also be you know, ambassadors of improvements in indoor air quality, which I imagine many of you are already, but hopefully this has added a few things. And again, grateful for the chance to join and speak today. Thanks for the invite.
Thank you so much, Dr. Piggott. Your smoking example is such a great example. And I even remember when Tim Hortons was, you know, and this is the late 90s, right before it was banned for indoors, they had that walled off smoking room in some of their franchises. And you would see people go in there and smoke, and it would get really smoky. And they'd finish their cigarette, and 5 minutes later, the air was clear again. It just goes to show, I mean, I'm not saying I want indoor smoking again, but it shows how powerful ventilation can be. It was just such a powerful, wish I had a video of that now. And even when you walk by, you would still smell it leaking out a little, though it wasn't perfect, but it was a very good example of how ventilation can remove contaminants.
Well, I think that's great. And Krista, if I can respond to that, I mean, you can see smoke, particulate matter, you can see, and I think that's been one of the challenges. You know, there's been a few really neat videos that have been created around, you know, if the aerosols were green or something like that, where they would be, and looking at spread and aerosols hanging there. I mean, I think if they were, if, you know, if COVID aerosols were green and we could see, it would be very different. It's hard. Our task is harder because of the invisibility, right? But it just means that the educational aspects are even more important and a little bit challenging, but definitely surmountable.
we have the same issue within occupational hygiene in terms of if a chemical doesn't, if it's not visible, it's not a particulate, and it doesn't have warning properties like a smell, think of carbon monoxide on its own. You know, the exposures can get quite high and you don't even know you have an issue. But when you have those warning properties, you have the smell, you have the visual dust, then people know there's a problem. And now I'm not saying everything that smells is toxic. Sometimes there's a smell and it's non-toxic, but it sends up that red flag. Something's not right here. I shouldn't be smelling this. And that's true. I got some questions from the chat. Can I go through a few? Okay. One question was, the hazard and risk of COVID is not absolute. Like, everyone has different risks based on their personal experience. So why not have a public health approach to protect those most at risk? And what is the role for advocacy?
Yeah, Krista, I think that's critical. I mean, one of the challenges with infectious diseases as opposed to other non-infectious or non-communicable diseases is the fact that normal risk people can pose a risk for high risk people, right? And this has been this challenge through COVID. I remember at the very beginning of COVID, there was a somewhat pejorative suggestion that high risk people kind of be locked up or separated, and you know, there be a protection of them, right? Just,
okay, you realize that's the reality now for many of us, though. Like,
you just wait to where I'm going, but no, yeah. For sure. So but that was actually, you know, suggested, and the reality is that was dismissed because that would be an impossibility. You could never completely isolate and protect people, and if so, for how long? So there was societal population level strategies taken, and I think you're right. I think that was Heather that was saying something, but you know, we've pivoted, and now there isn't the same protections that people at higher risk had through the pandemic. I mean, the reality though is everyone was at risk in the pandemic. I personally knew a physician who did not have risk factors, was not older, who died of COVID earlier in the pandemic, and so with the advent of vaccination, there's been an inflection point, and some people have gotten more baseline protection against that severe disease, not as much, but still some from you know, long COVID, PCC. But then
sure, but,
other
I mean,
people.
If you look at the data right now, since when we removed the majority of mandates last spring, and then you go on to the PHAC data, and you're looking at the number of outbreaks in hospital or long-term care or, you know, community care settings, and the size of those outbreaks and the amount of hospitalizations, the past year has been far higher than it has been for the previous two, when we keep scaling back measures. Like, yes to air, you know, I'm all for air quality, but is that going to be enough? Or is that going to be something we can do now that is going to protect people in high risk settings, particularly if they have high risks, such that they can, you know, go to get medical care or go to university? I've had to move my university program online. You know, I literally left public health to go back to grad school. No joke. First day in clinical placement, end up like winding up with preventable COVID, having risks, and have not been back to any type of full-time thing. This is the rest of my life now. So when I look at, you know, air quality and all these things we should be looking at, are we going backwards? I mean, this isn't like smoking where we had a normalized behavior of smoking indoor prior. We had a normalization of masking indoors. We're now rolling that back and then talking about rolling it back out if needed. Isn't that not sort of the harder route to go, where you're sort of going back uphill then?
Yeah, thanks, Heather. And I know there's probably lots of questions from folks, so I'll leave it to you, Krista, I guess, to manage, and I'm happy to respond to that one first. I don't disagree with you. I think that there is a significant challenge with where we're at, especially for people who are at higher risk of severe disease. I would argue we did not have normalization of behavior change on masking, and that is the challenge. Otherwise, we'd be seeing people masking still. right? And so I can't comment on policy or political decisions. I certainly provide advice. In my role, it's to local government, but I can't comment on decisions around that. And these are sort of societal decisions that have been made. And one of the challenges in public health is often there are decisions made for a variety of factors, not just health, and that can be sometimes frustrating working in public health, or deadly working in public health, for sure. So I mean, I'm not disagreeing with you, but what I do think though is we haven't had enough attention to IAQ improvements as part of the sustainable strategy. And if we had have known that, you know, the duration of the pandemic was what it was, and that the appetite to wear our masks was going to be what it would have been, I think there are other things, such as improvements in indoor air quality, that could have been done, you know, permanent policies around paid sick leave, et cetera, that could have presented more sustainable strategies, right? Yeah, but I appreciate the comments, and yeah, I definitely hear you, and sorry for the experiences you've personally had.
Yeah, I wish we could talk about that more. I'm going to move on to more questions, though. That was great question there. One question was about the name change from long COVID to post-COVID condition. When long COVID is better known, why is it sort of changing names a little bit?
This was the Government of Canada's decision around terminology with the CAN PCC guideline. The call was centered around PCC. So I think there's a lot of areas where there's sort of a medical name that's sort of picked, and then colloquial names that come out and happen as well. I think that will be part of the journey and process, is understanding definitions. And one of the challenges with long COVID or PCC right now is the spectrum of disease within and diagnosis, which is still, the science is really evolving. So I don't think we've reached the steady state and final understanding of that. And even personally, I'm really looking forward to learning more through that journey and process.
I'll just share within OHCOW, we have a monthly all staff meeting. And at the most recent one, I shared some of the long COVID data just to share that it's out there and what it is. And I shared the symptoms, and I got this all from Health Canada's website. So I'm not a physician, so I went with Health Canada. Here's their symptoms. And someone said, well, wait a minute, some of those are pretty non-specific. How do you know you have non-COVID? And I said, this is a question you have to make of your own personal doctor, because there are some very, some of those symptoms could be many things. So you need to talk to a doctor. Now, I know some of the people watching here are doctors with these questions too. So for those of you who are doctors, I don't envy your situation and having to diagnose this. And for those with long COVID, I wish I had something to heal you, because I have seen some of the stories, and some very, very hard. I have one other question from the chat I'm going to get to, and then Dahlia, I see your hands up, so I'm just going to, or did you want to, that was your question about long COVID, wasn't it?
Yeah, I was hoping I could sneak in. Sorry, I don't want to disrupt the flow.
No, this is the perfect time for it.
Okay. I also wanted to thank Dr. Piggott so much for everything you've done. I'm totally fangirling listening to the presentation, and I've been following your work and following you on Twitter, and I'm so happy to know there are people out there like you doing such good work, and it really gives me a lot of hope that we can get out of this pandemic, however long it may take, but there is an end. Yeah, and then just related to my question regarding the nomenclature on long COVID versus PCC, I was wondering if there's any distinction between the two, or if PCC is just replacing long COVID, because I know, as you mentioned, long COVID isn't clearly defined now, and there's so many different symptoms and conditions associated with it. So I would love to hear your insights on that.
Yeah, I mean, I would give a stay tuned answer if I can cop out of the answer to the question. I'm really curious to learn as we go through the CAN PCC guidelines, which I'm not speaking of about officially today, but I think that journey, and I'll just be one of the methodology co-chairs for one of the about 6 guideline groups that there'll be. But there's going to be, I think, a lot of learning through that, and I hope that we'll have better idea. I mean, I suspect that there will be an understanding that there is a constellation of both these syndromes and associated symptoms, the risk factors and kind of pathogenic elements. Like, I don't think there is this one concept of long COVID or PCC. I think there's probably a lot more learning that we're in the early days of on it, certainly based on what I've seen and heard clinically and hearing from folks. So I think that we need to understand, and we'll see as it emerges. It's going to be hard work with that long COVID PCC or CAN PCC guideline, because obviously this topic is very emotive. The pandemic has been a very emotive time, but I think that an evidence-based guideline is going to be really critical to advancing our collective knowledge of where we stand, where some of the gaps in research are, and where to from here. So look forward to it, and I wish I had a better answer now, but I think we will in the coming years.
Thanks again, and thank you to OHCOW for organizing all these amazing presentations.
The next question is, how do you balance the increase in confidence in vaccinations, increased ventilation, and indoor air quality efforts versus the need to mask? And I think this question has come up because we've been having a conversation at OHCOW. This is someone from OHCOW who asked, can we gather indoors to eat together? When we are working together, how do we safely have our lunch breaks together? Or can we safely do that together? So how do you balance those very, very complex situation?
Yeah, I mean, I think it's an evolving concept, right? I think that risk is this really complicated phenomena. I was doing some teaching with residents this morning and trying to explain why I take certain health behaviors, like not smoking, but I take other health risks, like climbing a mountain or scuba diving, and it is a risk-benefit analysis, and it's complicated. One of the challenges with COVID has been imperfect information, people not really perhaps understanding risk and benefit. There being debate on effectiveness of masking, but if we're talking about debate on the degree of the confidence interval, it's over here on somewhere along the fairly helpful to extremely helpful, not on the dangerous to helpful front. And there's been messaging problems, comms problems on that through the pandemic. All of that, I think, contributes to imperfect information and people unable to make some decisions on some of the preventative measures. On the flip side, on the risk side, I think also, data availability is really important. So we continue to update our Peterborough Public Health COVID-19 Risk Index on a weekly basis, as we have since we started it, which was in March 2020, shortly after I arrived. And the risk index, drawing from learnings with the AQHI, Air Quality and Health Index, is meant for both general population and higher risk individuals to have an understanding of the current risk, and we need a localized risk. So if I'm looking at AQHI and I see that in Vancouver the air quality is really bad right now, that's completely irrelevant information to me. So continuing to maintain multiple indicators and data sources to inform risk is important, and we're committed to continuing to update that risk index and using all the available data sources. As testing of individuals has been less available, we've had restrictions and or decreased uptake of PCR testing. We've had to utilize other mechanisms. So the risk index still draws from a rapid antigen test self-reporting survey that we've used and that we published a paper on in CCDR a few weeks ago or so, evaluating, and it's been an interesting data source and kind of a novel surveillance approach. We've also had to utilize wastewater surveillance data, and wastewater has become more relevant and important. Though there's challenges interpreting magnitude of transmission based on it, you can definitely see inflections in direction, increase, decrease. And wastewater can be helpful in other ways as well. In the same CCDR issue there, we published another paper looking at hyper-localized wastewater surveillance and trying to use it to dictate action. So we did this pilot project across 4 retirement home settings, sampling proximal wastewater to that home and providing that information in an actionable way. And in that kind of setting, you can see you go from 0 COVID in the wastewater, unlike now in the community level, we always see some. You go from 0 COVID in the wastewater to a signal, and a signal starts. And when you're sampling 2, 3, 4 times a week, you can quickly see a signal. And in that paper, we showed you can actually detect an outbreak before people are symptomatic and tested. And it's been less useful in the latter parts of the pandemic because incubation period and viral shedding dynamics have changed with Omicron and more recent variants than with prior, but potentially 2 to 8, 9, 10 days in advance of an outbreak being declared via traditional mechanisms, you could detect an outbreak via surveillance, wastewater surveillance. And for the higher risk settings, I think that's pretty cool because what you could then do potentially, I've thought about it almost a bit like a, if you've ever seen that pretty mediocre Tom Cruise movie, Minority Report, where they try to stop crime before it happens, I think that you can then implement and heighten people's attention to, we need to decrease gatherings, we need to improve ventilation even over and above our baseline levels, we need to really make sure masking is utilized, people need to stay in their rooms or home when they're sick, and you can, for a brief period, put the gas pedal on interventions to change the trajectory and potentially stop outbreaks. And I think it's worthwhile because I think that small investment really doesn't cost a lot to be monitoring. Can prevent what has also been a challenge through the pandemic is isolation in those congregate living settings where sometimes there's been a decreased care and either maltreatment or certainly isolation and neglect of people in those settings, especially seniors, and that's tough, and that can't continue. So we need to balance, but we know COVID continues to be very impactful and dangerous in those settings. So I think there's a lot of ways that we can address the risk question. Back to the original question that I've spoken way too long on, sorry, but I think that we need to be transparent on the risk front, what the current risk is in a way that's as actionable for people making decisions as possible. I also think we need to be careful to not unduly overplay risk at any time. Trust is a finicky thing. And so with the risk index as well, we marked out measures and recommendations at each risk level. And we try to be honest and trustworthy in our communication so that we can hopefully build trust from everyone that we're really speaking the truth, and as the risk elevates, people re-escalate their concern and hopefully preventative measures. But I think it's a journey, and we have a lot more to learn on the risk communication front in COVID and in public health more broadly too.
Okay, there was one question. You talked briefly about COVID in the past as if it still isn't a pandemic. So I just want to clarify, we agree it's not endemic, it's still pandemic?
Yeah, I was answering this question to somebody earlier today, and they said, is the pandemic over? When will it be over? I mean, I think that's a quote unquote declaration that will be made in the rearview mirror. Again, like I mentioned, 3 people in my region. I get an email every time somebody dies of COVID-19 still, and I read all of the details to better understand. 3 people in our region have died in April 2023. And so as much as the dynamics have changed thanks to vaccination, thanks to available treatments, and the pathophysiology of more recent variants have been different, partly as a result of those interventions, but partly due to a different pathogenesis compared to earlier strains in the pandemic. For all those reasons, we're in a better place, but we're not out of it. And I think it's not going to be this kind of on-off switch. It's this slow taper. And at some point, we'll probably look back and sort of say, this is when the worst of it ended, if we may at all. I mean, with HIV, that was one that it was before my, the most acute phases of concern, public concern, were before my time in public health, but we still constantly deal with HIV infection, and it's part of the public health response all the time now. And so with the waning of public attention, that doesn't necessarily mean a burden of disease has gone away, right? And so try to be careful in the communication around this, but no doubt improvements have happened, and we're in such a better place because of vaccines. Could we be in a better place? Will concerted effort on IAQ help? Yes, of course, yes. But we are not in March 2020, and that's a good thing. Now, were we to have a new pandemic hit in a year or two of a completely different pathogen, would we be in a better place? I mean, in some small ways, yes, but not nearly as much of a better place as I'd wish. And we see this, the Chief Medical Officer of Health of Ontario's annual report talked about a boom and bust cycle of public health funding. Same with the Chief Public Health Officer of Canada's report, a boom and bust cycle of public health funding, and not only for public health but the other sectors. If we keep throwing water on an oil fire well after it's burning, we're not going to get ahead of things. We need to have preventative strategies. I like the fire metaphor because, we're in such a better place with fires. We don't see nearly the loss of life and significant impact. And it's not because we've bought more fire trucks to flame out the flames and bells and whistles to respond to fires. It's because of building code and structural changes that have made buildings more safe and fires less likely.
I've never thought about that analogy before. That's a great one. Earlier in the presentation, you mentioned a link to science.gc.ca related to long COVID. Are you able? I think that was what. Are you able to put that in the chat? Making you.
Yeah, I'll drop that in. Yeah, I'll drop that in.
Okay.
Yeah, I got it. I'll put that one in, and I was going to put something else. I'm trying to remember.
Yeah, there's something else in there.
I was going to put the link to the PCC guidelines, and on the bottom of this website, there's a sign up form, get involved. So here's the PCC website. And here is the apply to participate survey. There you go. That's the direct link, the second one, to apply to participate. Yeah, no, thanks, Krista.
Okay, have you relaxed masking requirement? You talked about you still have to wear masks at public health, but have you relaxed masking for when people are eating? Are they able to eat together?
Generally what we've done is linked it to the risk index. So we're at low risk now. And were we to go back up to high risk, it would change again. But in the spaces that people are eating, we've done IAQ assessments and looked at ventilation. And yeah, I mean, people can eat together. We still encourage, outdoors or different things like that. And there are other ways. But yeah, no, we certainly are now.
I think we're getting some thank yous in the chat. I'm just reading through right now to find more questions. One person says, I wonder if we need to change our language a little bit. There's a dichotomy for acute severe disease where there's clear risk factors, but there's also medium, longer term severe disease, be it post-viral syndrome, post-COVID chronic disease, and everyone seems to be at risk, including children and those with no pre-existing conditions. So this person is saying, in her opinion, we need to change the narrative. Severe outcomes could be both acute and longer term. More of a comment, I guess, than a question.
I think it's a great comment, and I think that's kind of the continuum of disease and learning that we will hopefully have over time. I think that it will be something we'll learn a lot on, not just through this guideline, but as primary science literature evolves as well on the topic.
Okay. Are you tracking excess deaths in your region other than COVID deaths? Because we've had, actually it was Dr. Tara Moriarty on, and she's tracking excess deaths with the theory that now she is accounting for opioid related deaths, but she is having a theory that there are excess deaths related to COVID that are not getting attributed to COVID. Are you tracking something like that in your region?
It's not part of our primary communication, approach, but I think it's an important point. There certainly are likely to be excess deaths. When you just think about, confirmatory testing, we're likely missing some, but it's not something that we're really doing locally.
Okay. Probably very hard to do when you're in the middle of it. One of those, unfortunately, seems more like an academic exercise after the fact, looking backwards, as opposed to in the middle of it.
Yeah, and there's still many people dying, like I mentioned. I think even the direct deaths are compelling for continued attention and vigilance for sure.
Okay. Do you feel it's important to differentiate between masks and respirators? So the research, the question is being asked, the research is identifying better performance with N95s and other respirators. It's not always understood well by the population. Is this something that should be focused on, or is any masking, just using the term mask to encourage face coverings, is that going to give us some benefit? Especially, I'm thinking, I'm reading between the lines in this person's question and putting my own slant on it too. Someone is not masking at all now, wearing something better than nothing, or should we be focused exclusively on pushing the N95?
Well, generally in public health, we support harm reduction perspectives and approaches. I think there's always some things better than others. I think if if an intervention we were recommending was freely available, and or with something like smoking cessation, people could save a lot of money. It changes the tone, the framing of public health messaging. But for the last year and a half, 2 years. Tighter fitting masks, which has been largely my language, have been fairly well available and or sometimes freely available, lower cost. So I mean, I think it's certainly an important consideration.
Okay, I see some hands up. I didn't see them before, and I'm trying to pull them up now. I'm not sure whose hand was up first. I'm trying to figure out if I can do that. Right now I see Dorothy's hand up, so we'll go to Dorothy first. I'm sorry if you weren't first.
I have no idea whether I was first or not. No, my question, Thomas, just had to do with all the work that you've done around with these guidelines and through the Board of Health and stuff. I'm just curious about what kind of reaction you've had. It's great the media is paying attention, but who else is paying attention? And I'm particularly interested in whether other public health units are taking up a similar position.
I think it's a work in progress, having lots of those conversations. We have an association of local public health agencies that health units are part of, trying to, through it, advance some kind of policy and shared recognition of the importance of indoor air quality. So there's lots of behind the scenes kind of pieces around that happening. I know at least one other health unit, Niagara, last year had their board had passed very similar language and resolutions to recognize the importance of indoor air quality, especially in the context of COVID-19. So I think there's some.
Mm-hmm.
I certainly wish there was more, and have been working on that and will continue to.
And so related to that, then the obvious question is, what help do you need and where? And I'm just thinking of occupational health folks. I'm a hygienist. There are people like Joey and others. David Elfstrom, I saw, was on here, who's ventilation engineers. I keep on saying to people, I've got 2 filing cabinets full of materials about indoor air issues from the 80s and 90s. It's been an occupational health issue for that long
time,
at least.
yeah.
So what help do you need, and who might be, whose door would you be knocking on if you were looking for it?
Yeah, no, thanks, Dorothy. I don't have a good comprehensive answer to that. I think I'm still trying to find the allies and advance and understand. where different people, different folks are at around around this issue in particular. I think if we look back historically to other public health issues, notably smoking, in Ontario, advancement in public health has started in agreeable locations at the local level and began spreading from there. and you reach a turning point where there's, you know, a groundswell and broader support. That then means that the provincial government often changes course and provincializes something. So this has happened dozens of times around smoking, that there are more progressive on a topic health units that really lead the charge, local municipalities lead the charge and support, and then it expands from there. I was really pleased to see the IAQ incentive from a federal government tax standpoint. I think there are federal government windows and interest. They have a role in, for example, the building code, though it is largely, you know, provincial. I think there are windows politically there, and then at the local level, I think there will be support in different areas. You know, when we think about advancing policy, we often talk about political windows. And a policy window, as at least Kingdon, one of the theories suggests, is when there's a convergence in the politics, the problem, and the policy or the solution, the 3 Ps. So I think that if we can, local, provincial, federal, look for a convergence of the problem, which hopefully was pretty clear and was big in the last few years, the solution, you know, as in here, specific policy solutions, you know, let's look at some key areas in public where we could make IAQ safer, either through incentivization or, you know, bylaw or, you know, penalization. Let's look through those various levers at key areas, and provide some key solutions, cognizant of fiscal challenges and context and all that, and then you get the politics stream converging too. And I think that's when you have a political window that you can push, you know, progress on important issues through. So I think if I was interested in that, I'd be looking at those in key local areas, then too at different levels of government.
Well, don't forget us OC Health and OC Hygiene folks. Thank you.
Hello, Dr. Piggott. I see Krista's, she's not there anymore. I'm not sure where she is. So I just want to thank you firstly for presenting to OHCOW and, you know, your leading practices and providing great leadership. But I specifically wanted to ask you a question about outbreaks. So I think, you know, sometimes you'll see an outbreak in a long-term care facility, and then maybe a month or sometime after you'll see another big outbreak in a long-term care facility. And I kind of got thinking about, you know, what kind of incident investigations are being done, and, you know, and maybe the inspectors of these long-term care facilities and other congregate setting, you know, places. What kind of training is there provided to these inspectors on doing a very good incident investigation, which includes root cause analysis? Because you'd think if there's a good investigation, then controls that would be put in place towards these other facilities. And some time ago, OHCOW provided a webinar on incident causation accident methodology, you know, which provides a framework around incident investigation. I'm just wondering if you mind commenting on that. Thanks.
Yeah, it's really interesting. I mean, I think part of the challenge is that we're not really enshrining IPAC practices that align with an airborne disease into some of the IPAC guidelines yet. Certainly here locally we are and advocating, but it's an important piece that, you know, needs to come through provincial guidance and expectations, especially to be more enforceable as opposed to, you know, finding allies and finding people that want to do those kinds of things. you know, I think the IPAC world on this topic's been thrown a bit upside down, and there's a lot of learning to be done on this. But you're right. If there's multiple outbreaks in the same facility, multiple periods in a row, at some point, you know, Einstein's definition of insanity should prevail, and we need to be doing something different. I think locally we're trying to equip and support. I'm really glad that one of the key vehicles for this education support and inspection of long-term care retirement homes in particular has been IPAC hubs, and the funding was just recently announced to be extended for one more year, but it hasn't been created as a permanent structurally funded solution yet. And those IPAC hubs have been pretty helpful to providing input and response and support. But I think there's a lot of work still to be done, and your suggestion around that learning is sage. So thank you.
Thank you.
Thank you. Krista lost contact. She may be coming back in on her phone, but and we really appreciate you staying over time, Dr. Piggott. We have one more hand up here, which is Julian, and then I assume you probably have to go. But Julian, can you?
Yes, I'm sorry. I just had someone come in. That's what happened when you work from home. So first of all, great presentation. It's really, really fantastic that we have people like you working on stuff like this. I've been personally looking into indoor air quality ever since COVID started, and I was just baffled that a lot of people, doctors and scientists, were just seem to be missing the point that respiratory diseases are transmitted through the air. I mean, for me, it was just self-obvious. But I just wanted to your input regarding the fact that even though that we're putting a lot of measures in place, PPEs and accounting for indoor air quality, at least for human occupied building, that we probably aren't addressing the root source cause of those diseases themselves. I don't want to go down a lot through that rabbit hole, but from my limited understanding, from what I understand of these, where they come from, a lot of these pandemic diseases or epidemic diseases seems to be coming from zoonosis spillover. And if you have ever been to a pig farm, the quantities of living being that we put in closed spaces with not accounting for indoor air quality whatsoever is just source for transmission. I've been to an Ontario pig farm last week, and it's just horrible, the kind of diseases that are spreading in those places. And even though a lot of virologists will tell you that diseases normally don't spill over from animals to human, unless when they do, and then when they spread to humans, they don't spread between humans, except when they do. It just seems self-obvious that it's just not going to be 100 years before the next big pandemic unless we do something to address transmission between animals also.
Yeah, I agree. I started my education career at University of Guelph, where the Ontario Vet College is, and you know, part of my core training was in One Health, right? The interconnectedness of humans and animals, and the importance of zoonotic diseases. So I totally agree, and I think it's an important consideration. And even beyond human and animal health, you know, the model in certainly addressing climate change crisis and broader perspectives is the importance of planetary health. It's not just humans and animals, it's the health of our planet, and we need this holistic view for sure. So I don't have a lot to add. I will just agree with that piece. And perhaps to end on, I mean, I think this is a long journey and is potentially going to be a continued area of frustration, and for people advocating and trying to work on this, you know, persist. But it brings me kind of solace looking back to the challenges that, you know, various people in history have had advancing issues. One of whom is Dr. You know, John Snow. I've got his cholera map here. He was the one that sort of
Krista, are you back? Do you want?
I think I'm back. So thank you so much, Dr. Piggott. We really, really appreciate your time today. The chat was just filled with thanks towards you. So thank you so much on behalf of everybody watching and on behalf of OHCOW. We were so appreciative you were here. Thank you so much. To everyone else, the recording will be available next week. And I think we'll wrap it up there. Next week, next Friday is the day of mourning. We will be having on COVID, addressing COVID-related deaths with our Dorothy Wigmore. OHCOW's Dorothy Wigmore will be with, say ours, there's some belonging there. OHCOW's with journalist Nora Loretto, who has been tracking COVID-related deaths. So that will be the focus. But of course, Day of Mourning is in honor of everyone who has lost their life for work causes. So if you aren't able to attend, please try to at least honor the Day of Mourning. Thank you so much, everyone. Have a great rest of your day.
Thanks. Thanks again, Dr. Piggott, for all your leadership. Bye, everybody. See you next week.